It's a time of optimism in cancer medicine, and I think that there's a really bright horizon, and the advances happen all the time. And so, one of the strategies that patients need to think about is, I need to let the advances catch up to me. Like, we're going to control this disease over time. Our strategy is going to be to adjust and pivot and react to the changes, and that we're going to run a marathon together, and we're not sprinting towards a finish line. And immune therapy looks like one of the best pathways to accomplish that goal.
Welcome to Your Body, the healthcast that takes a deep dive inside your health. No matter what kind of health issue you're experiencing, whether it's the common cold, a bad case of eczema, heart disease, or breast cancer, it affects you in every way, physically, mentally, emotionally, and internally. This podcast seeks to understand what is going on with our bodies from the inside out, from our heads to our toes, and everything else in between. We're going to look at health issues from every angle and hopefully get a better understanding of what's going on with our bodies and how we can better take care of them. I'm your host, Stephanie Landon, editorial manager at RadNet, a leader in outpatient imaging services and an advocate of patient empowerment for over 35 years.
That's right. Chemotherapy poisons the immune system. Immune therapy is a way of trying to strengthen the immune system.
It sounds almost futuristic, harnessing the power of your own immune system to fight diseases. This is immunotherapy, and it's becoming a core part of cancer care. But in fact, using the immune system to fight cancer and other diseases is not a new concept. In the late 1800s, German physicians found that injecting a bacteria into tumors caused them to reduce in size. In 1909, American surgeon William B. Coley employed the same concept to treat bone cancer, but his achievements went largely unnoticed for over 50 years until researchers and physicians began to better understand the human immune system. In 1967, several discoveries in the field of immunology, such as the existence of T cells and their role in immunity, helped to step up the research toward cancer immunotherapy. Still, it really wasn't until the last several years that research advances in immunotherapy have seemed to really intensify. This has opened the door to so many incredible treatment options and research breakthroughs, including cell therapies, immune inhibitors, and even the possibility of cancer vaccines. In essence, the standard of practice in cancer treatment is currently changing at an unprecedented rate. We really are living in the future.
Maybe we all have cancer cells in our body all the time that are under the surveillance of an intact immune system. And when cancers grow and spread, part of the reason they do that is because the immune system has failed its job to detect and eradicate those cells.
Dr. David Hoffman is Medical Director of Tower Hematology, Oncology, and Professor of Medicine at Cedars-Sinai in Los Angeles. He is a cancer specialist, which means he diagnoses and treats cancers of all types, and he's also trained in blood disorders and the medical treatment of malignancies. He has done research focused on immune therapy for cancer treatment, and he incorporates immunotherapy in his treatment of patients when suitable. Hi, Dr. Hoffman.
Hi.
Hi, Stephanie Landon.
Hi.
How are you?
Oh, doing well. How are you?
I'm good, thank you. Well, thank you for getting on with me today.
Well, thanks for having me.
Thank you. So we're doing the podcast, and we're talking about immunotherapy. And
it's great. It's one of my favorite subjects of all time. So it's great.
Awesome. Well, I definitely am excited to talk to you about it. And maybe you can start by just sort of giving me like just an overview of it, like what it is and how you use it.
Yeah. So right. So historically speaking, in the world of cancer medicine, there's been a couple of different philosophical approaches to treatment. And one way to divide the treatments in your mind is talking about what we call local therapy, meaning treat a very localized part of the body. And of course, the The ultimate in local therapy is surgery, where they remove a part of the body. Another very commonly used local modality is radiation, and there are others. And then there are treatments that we consider to be systemic therapy, meaning to treat the whole body. And most of what medical oncology does is systemic treatment. And historically speaking, that's typically been focused on chemotherapy. And the word chemotherapy is not a very helpful word. It's sort of just a catch-all phrase. But what it really means is that chemotherapy as a class of medicines is simply a non-selective, non-specific poison that poisons dividing cells. So it doesn't recognize cancer cells. It doesn't recognize healthy cells. It just poisons dividing cells. And the rationale, simple-minded though it is that in general, cancer cells are more rapidly dividing than healthy cells. And so the hope is if you poison the whole body, you would poison cancer cells out of proportion to the healthy cells. And of course, all of the side effects of chemotherapy are from the healthy cells that are poisoned. And most of those side effects are irritating or they're annoying. They're not dangerous, except there's an organ in our body that is rapidly dividing that we depend upon to be safe every day. That's the bone marrow. And the bone marrow is the source of all of the blood and the immune system. And so chemotherapy poisons the immune system. And the truth is what we stay awake at night worrying about are the infections that can happen from chemotherapy.
Right.
So, there's been a belief that one of the ways that cancers grow and spread is by avoiding detection by the immune system. And that maybe we all have cancer cells in our body all the time that are under the surveillance of an intact immune system. And when cancers grow and spread, part of the reason they do that is because the immune system has failed its job to detect and eradicate those cells. So there's been a longstanding hope that maybe we could make the immune system a little bit smarter and a little bit stronger, and the immune system itself could fight the cancer. And if you think about it, that's actually the opposite of what chemotherapy does, right? Chemotherapy poisons the immune system. Immune therapy is a way of trying to strengthen the immune system. So one of the reasons that we have some real hope about this idea is that in the past, there have been observations of patients with advanced cancers on no treatment at all who go into a spontaneous remission. Wow. That is a very strange thing to happen. And the reason that it happens in those rare cases is because suddenly the immune system wakes up, sees the cancer, and goes and fights it. And so with that observation, that led to a series of different experimental ideas going back to the 1980s that mainly came out of the National Cancer Institute in efforts to try to strengthen the immune system. So it's been sort of a long journey. And in those days, immune therapy was really considered sort of, a very ineffective way of trying to treat cancers, that chemotherapy was where the real money and the real muscle was. But we've learned over time that immune therapy, when the power is harnessed and targeted, is not only an effective treatment, in many cases, it's much more effective than chemotherapy.
Yeah. Yeah. Well, it seems like it's sort of opening a lot of other doors also. I mean, it's, opening doors to vaccines, and it's really quite amazing how harnessing our own immune systems, is proving to be so much stronger, or it could be potentially.
Yeah, agreed. Yeah, no, you're right. And it has opened up many, many new avenues of research as well as therapeutics. And vaccines is one good example. So, we've been working for decades trying to sort of figure out a way to vaccinate against cancers, including the sort of the semi-science fiction dream of vaccinating children against getting breast cancer, for example. Right. So, and while that sounds sort of futuristic, the truth is we're not that far away from that kind of an intervention. So what we started off with back in the 1980s was a way of trying to expand T cells. So T cells are the sort of the soldiers, the Marines of the immune system, and growing T cells either inside a laboratory and then giving them to patients, so what we would call cellular therapy, or expanding T cells inside a living patient, we call in vivo expansion, was the first attempt at doing this. And what was interesting was a couple of things. There were some important observations. One observation was that treatment, when given in vivo to a living patient, was really toxic. It was actually much more toxic than chemotherapy.
Oh.
But in a subsegment of patients, it cured them from cancers that otherwise were incurable. And so that was an amazing finding. And that led to refinement of immune therapy over the last 25 years, to the point now where we routinely give immune-stimulating medicines, pure immune therapy, every single day as an outpatient to patients with a variety of different tumors. It's also led to an advent called CAR T cells, which are taking a patient's T cells, taking them out of the body, programming them to go find a cancer cell, and then re-administering those cells. So this is technology that did sound really futuristic, is now in the clinic all over the place and being utilized to this day.
Wow.
And another really sort of an unexpected finding was that radiation, which I mentioned is really considered classically a local modality of treatment. There were some experiments that showed that if you radiate one part of the body, you could get response in a different part of the body, which was really an amazing finding. And what they found was radiation induced an immune response distantly from the site of the target, so-called abscopal effect. So radiation therapy, and maybe surgery will as well, actually has immune stimulatory benefits. So really, really exciting time for immune therapy. It's still just the beginning of the true revolution, but cancer therapeutics, the way that we knew them 20 years ago and the way that we'll know them 20 years from now, will be unrecognizable.
Yeah. So you really do foresee a future where this sort of becomes more of the norm in cancer treatment?
I do. I think, there's probably always going to be a role, although limited one, for classic chemotherapy. There's a handful of diseases that chemotherapy really is a solution for, is very effective, and the side effects are much more manageable now.
Right.
But if you look at the biotech industry and what's being developed, chemotherapy drugs are not the ones being developed. These are all much more postmodern therapeutics, a lot of it immune therapy based or immune therapy with targeted therapy. As we've unlocked the human genome and as it becomes very routine to do genomic sequencing on tissue, the individualization of treatment has become a very major facet of our care. So one of the fun things and challenging things about cancer medicine is we get to make really complicated and difficult decisions every day, and they're really based on ethical principles. And so one of the ethical principles that we think about a lot is called distributive justice. And what that really refers to is that it would be optimal, although it's not really real in our society, that there was an equal distribution of resources, that the population was all treated equally. And we know that our system is much more inequitable than that. And so instead, what we've replaced that with is something called the standard of care. And the standard of care is there because if you treat the population with the standard approach, the population will benefit. Of course, any individual person might not benefit. And the field recognizes, the science has proven that there's a lot of variability among individuals. And there's a strong movement towards personalized medicine. And immune therapy is a big part of that. So we're going to be able to really individualize treatments at the personal level and harness the power of the immune system.
That's really exciting. And this is all sort of, really kicked into high gear over the last few years. Is that right? I mean, it's been around for a while, but it's kind of escalated.
It's accelerated dramatically. Yeah. Over the last several years, there's been a dramatic acceleration at the research level, at translational science. So, in order to make advances in cancer medicine, and of course in any scientific endeavor, there has to be experimental efforts. And one of the obstacles that we've faced in North America has been patient reluctance to participate in clinical trials. Less than 3% of patients are willing to enroll in studies. And without patients enrolling in clinical trials, we can't find better treatments. And every treatment we have came through experimental work. So we're hopeful that as the treatments become more exciting and less toxic, we'll be able to recruit more patients and more people to enroll in studies. But there's been a true explosion in the use of immune therapy. Of course, we have anxiety and concern about some of the societal costs of immune therapy. The treatments are not inexpensive.
Right.
And it's interesting now. So, for example, in lung cancer, which is a very common tumor in North America, the standard of care for the routine lung cancer, unless there's an exception, involves giving immune therapy along typically with chemotherapy to all patients. And you can imagine that can really escalate in terms of the societal costs, and how much we can bear and what our system is willing to tolerate. So there's going to have to be a correction in terms of the systematic approach to spending and expenditures and what the economic forces can tolerate.
Yeah.
But I think hopefully as immune therapy becomes more widespread, the cost will come down.
Right. Like in terms of insurance covering it and that kind of thing.
Right. So now the manufacturers, most of the pharmaceutical companies are willing to donate drugs, but that's not going to last forever. And at some point, there's going to have to be a reconciliation. Right.
Yeah. Got it. So what do you recommend to a patient who comes in with cancer? Like to someone who's listening, who's maybe newly diagnosed, like what kind of advice would you give them in terms of what to ask for?
Right. It's a great question. So it's funny because a lot of patients come in a little bit almost embarrassed to tell you that they've been doing some research on the internet. I think that's a great thing to do. I think that patients should read about what's going on. And an informed patient is always more empowered. And so, I think that patients need to feel like they're a partner in their care. They need to feel that there's a good fit with their treating physician and their team, and that they need to explore options. And so one of the things that we tell patients at every decision point, we always ask the question, is there an experimental treatment that's an opportunity that we could participate in? So there may or may not be. And so I'll tell patients, it would truly be my privilege to take care of you. However, in the end, all I care about is that you get well. And it doesn't matter to me where it is. It matters to me that you get well. And so I strongly encourage getting second opinions, and patients should ask, where should I go for a second opinion? Is that okay? Do you think that's a problem? Is my cancer a curable disease? It's a critical question to understand at the very beginning, because the goals and the treatments really are different if the patients have curable or incurable cancers. Almost all cancers are treatable, even if they're incurable. And so if we're in a situation where there's an incurable disease, we want to know, what is the opportunity? What is our goal? What are we trying to accomplish here? Is immune therapy, for example, the right thing for me? And to be curious and to be, it's not, especially nowadays, it's not okay to take a very passive approach to your care. You have to sort of be proactive and bring somebody with you and take notes and ask probing questions. And in the end, it's always about the patient and the fit. It's never about the doctor. It's about the patient and making sure there's a team that's there and ready to, quarterback this, what can be a complicated project, and do it as a partnership.
I want to stop for 1 minute and emphasize something interesting that Dr. Hoffman brought up. He mentioned immunotherapy being a component of individualized care. In a nutshell, individualized care generally refers to patient-centered care, meaning that as a patient, you are a partner in your medical treatment. It's not like the days when your doctor just looked at a chart, gave you a prescription, and you didn't ask any questions, you just took the medicine. It also means that doctors should be looking at the whole patient when diagnosing and prescribing, taking into account the emotional, financial, behavioral patterns of the patient. In fact, a study from the University of Illinois and the U.S. Department of Veteran Affairs found that patients' health outcomes actually improve when physicians individualize care and take their patients' life circumstances into account. What's interesting about Dr. Hoffman's correlation between immunotherapy and individualized care is that it indicates that we are moving toward a system where the very treatment we receive is individualized so specifically that it is developed for you and you alone. That's some pretty empowering stuff.
Common musculoskeletal injuries account about 100 million office visits annually just alone in the United States.
Dr. Daniel Amirhamzeh is a musculoskeletal radiologist at RadNet's Beverly Tower Wilshire Advanced Imaging in Los Angeles. I'm talking to him about platelet-rich plasma therapy, or PRP. In the same way immunotherapy strengthens your own immune system to fight disease, PRP harnesses your body's own healing capabilities to grow, repair, or replace damaged or diseased tissue. You may have heard about famous athletes like Tiger Woods or Rafael Nadal making miraculous quick recoveries from injuries, and they credit this to stem cell therapy or PRP therapy. And both of these are forms of what is called regenerative medicine.
So what is PRP? PRP stands for platelet-rich plasma. So the platelets, also called the thrombocytes, are the blood cells that cause blood clot and necessary for growth healing factors in the body. So on average, just you and I, we have about 200,000, platelets in our per microliter in our body, but the range goes from 150 to 350,000. And but PRP is basically the higher concentration than the physiologic plasma.
Before we go further, let's do a quick anatomy recap. Plasma is the liquid portion of your blood. It's composed mostly of water and proteins, and it houses red blood cells, white blood cells, and platelets, all of which circulate throughout the body. Platelets, also called thrombocytes, are blood cells that cause blood clotting and other important growth healing functions. Platelet activation plays a key role in your body's natural healing process.
The PRP is about 1 million, basically platelets per microliter. And how do we get this PRP? It's basically collected from this, venous straw. We put it in a centrifuge. It spins, and it actually gives you 3 layers. The top layer is called the platelet poor plasma, which we don't use. The middle layer is going to be platelet-rich plasma, which we use, and then the bottom layer would be the red blood cells that get discarded. This whole procedure takes about 15 minutes to spin, and then you get this, at our center, we're aiming for almost 10 times the concentration. So, we have really good, I don't know if I could say the name of the company or the vendors that we use, but, they have one of the best machines in the industry. And so platelets or PRP has been around for the past 30 years, but recently it's been getting more popularized by media after positive effects among professional athletes and Super Bowls, and you see these athletes who have injuries and they just come back to play sooner. So it's got some media attention recently, but previously, just a little background history on the PRP, it used to be used a lot by oral surgeons when they used to do oral maxillofacial surgery, and they would just inject at the site of the surgery the PRPs, and they would see results where the healing when compared to the people who don't get the PRP, the bone healing would be 4 weeks even more advanced, just in comparison. So because of that, there's been a significant increase in the volume of ultrasound-guided treatments by radiologists, specifically musculoskeletal radiologists like me. And the most common indications are chronic tendinopathy. What that means, any tendon in your body from basically shoulder down to your ankle, we could inject. Other common indication is the plantar fasciitis, which is the most common inferior heel pain in Americans. About 2 million people are affected each year by plantar fasciitis. You look around, ask your family members, a cousin, a friend, someone has plantar fasciitis.
Yeah.
And also, like in acute ligamentous and muscle injuries in athletes, like MCL or hamstring, injuries in terms of like a muscle injury. And these are like really kind of like prone to like re-injure, and it takes a long time for them to heal. So it's important to kind of have a healing process to be shorter and faster, with less being prone to re-injury. And again, PRP is a natural way to kind of stimulate and augment healing response in the body. It treats the underlying problem instead of addressing the symptoms, like steroid injections.
Right.
It's cost effective. As I said, it's faster recovery, and it's minimal invasive and low risk because we're using a needle as opposed to, taking somebody to the surgery and, open them up.
So
Okay.
I wanted to ask you, you said that maybe a patient would need 2 injections?
Yeah, so my goal is to do 1 injection. So basically, when I try to like screen the patients, we look at the MRIs of the patients, and we're just gonna select the patients who would benefit from PRP the most.
Right.
I mean, there are like a lot of maybe clinics that you just show up and they were just gonna do the PRP injections, or they would say like, we're gonna do like 5 or 6 for you.
Wow.
We're not like that way. We're just trying to like, find the right patient, do the right injection, and have like the great, like, post-procedure kind of like follow-up or regimens that we have to make sure 1 injection should be sufficient for the patient's injury. That's our goal.
And are the effects of it lasting?
Yeah, the effects should be lasting, like, maybe 1 injection, 2 the most, with how we do it in RadNet.
Wow. That's amazing. Very cool.
We have several indications for PRP. As I said, this is more like for the soft tissue injuries, which includes muscle, tendon, ligaments. So if you go from the head and from neck below, shoulder rotator cuff tendon is the most common one. And then you go lower to the tennis elbow, which on the lateral side, it's called the lateral epicondylosis, where you get like pain. A lot of times, like it could be just an average person, but a lot in the tennis players. And there's so many research on PRP show that even 1 injection has decreased the pain level 80% at I believe it was a 6 months follow-up and a 93% at 25 months follow-up in comparison to their own baseline status. Just 1 injection to the elbow.
Wow.
And then you have patellar tendinopathy, where your kneecap, below your kneecap, there is not much. These are the tendons that you usually, like, when I'm going to talk about this, you can't have like, a surgery and have a good outcome. Like your tennis elbow is 1, your patellar tendon is the 2nd, and then your Achilles tendon, where you can't walk. This could be very debilitating for the patient. It's going to cause significance to the health economy, to our society, because patients can't walk because of the Achilles tendon. And you have plantar fasciitis, as I said, 2 million people every year are affected. And then when you go to more like an athlete levels, like when you have like acute, like, ligamentous injury, MCL, very common in soccer players or even football in the US, where it's very like, prolonged to heal. And when it's healed, again, it's very prone to re-injury. And we have ankle sprain as well. And also the muscle injuries, most common being hamstrings. So these are like, very indications for the PRP in terms of the soft tissue injuries. We also use PRP to do for cyst aspiration. When you have a ganglion cyst on your wrist, or you have a popliteal cyst in your knee, when you actually aspirate and you inject these cyst walls with PRP, it kind of forms, it acts like a sclerosant agent. So it's basically adheses the cell walls together from reaccumulation. So that's another benefit of using a PRP.
Wow.
Yeah.
That's so cool.
Still with me.
I feel like I have about like 4 out of all of those ailments. Can I just like run an IV of it through my whole body?
Yeah. The problem is like if you do it with an IV, the blood it doesn't go against these soft tissues because it's limited. So you have
Right.
to actually locally inject. The indications are like, I mean, endless. Like, I mean, anywhere you have pain, even if you have a fracture, I have a mentor, Dr. McKinley, in Casper, Wyoming, and his wife actually broke her toe, and he injected PRP to the next to the fracture site, and it just healed faster than you would expect, with just like a normal just like healing process. So the possibilities are endless with
Yeah,
PRP.
that's what I was going to
Sorry, go
ask
ahead.
you. I was going to ask about, the future of it. It seems like it can be used in so many ways. I mean, endless. But is it not covered by insurance? Is that one of the
So
issues?
that's another thing I was going to talk about.
Yeah.
So the problem is the insurance companies don't cover this as we speak.
Yeah.
But we're going to try to encourage our patients to kind of like submit it to their insurance. I mean, even though it gets denied, but once the insurance, they see multiple attempts, they may just change their policies.
Yeah.
But yeah, unfortunately, in California at least, this is not covered by insurance, and it's cash, out of pocket cash, basically.
Yeah. I mean, I would think that, the long-term benefits of it, it makes sense that they would start to cover it,
Yeah, because you're gonna avoid people missing work and surgeries, and if you think about it, like this is very cost effective, and I'm surprised that the insurance companies haven't agreed to pay for this.
I know. It seems like it takes them a long time to come around to new things.
The day of the procedure, when they come, we just do a venous draw, a blood draw, and then we send it to the centrifuge machine, and it takes like 50 minutes for the PRP to be ready. And then we use the 22 gauge needle under ultrasound guidance in a sterile technique to kind of target the sites. And we give the patients kind of like a post-treatment care, kind of like a brochure, just to reiterate, because the patient compliance is the most effective thing. Like the patient could be compliant with the post-treatment care, they get the maximized benefit of this procedure.
Right.
We're a little harsh here in RadNet because a lot of sites, they could just do an injection and the patient walks out of the clinic. If we do injections kind of like in the lower extremity, we tell the patients to be at least 2 to 3 weeks non-weight bearing plus a brace. And then after that, we go partial weight bearing for 3 weeks with brace. And then we incorporate physical therapy, weight loss programs, muscle strengthening programs to get the best benefit.
Right.
And when I said non-weight bearing, it's going to be hard for people for like 2 to 3 weeks not to walk. I mean, they still could go use the restroom and shower without crutches, but we really want all this, injection at the site to be doing their magic and heal as opposed to walk. One analogy I usually tell the patients is that, I mean, when you see construction workers, they put like a new asphalt on a new hole, there's this cones all around it to make sure this asphalt actually sticks. So we don't want cars to be running over that new asphalt, because then it's just gonna go back to square one.
Right.
So that's why we try to have the patients to be kind of non-weight bearing for at least 2 to 3 weeks, just to make sure that this injection actually works. And that's why we have more successful rate. We're just gonna do 1 injection, max 2, as opposed other clinics, they just do they schedule you for oh, come back every month for 1 injection, and the patient walks out of the clinic and they don't see the result.
Right. Well, that makes sense, actually. How much blood do you have to take?
So basically, depends where we're gonna inject, but 20 to 30 cc's is average. And that would give us I would choose maybe 30 cc, and that would give us a tenth of that, 3 to 5 cc of concentrated PRP.
Right. So you need a decent amount.
Yeah, I mean, this is not much that the patient is gonna be fainted or so we're and yeah.
Right.
So
right.
We're not gonna take a liter.
Right. Okay. Maybe they'll need a cookie, but that's fine.
Yeah.
All right. This is so interesting, and I just think it's amazing that we're looking at treatments that use the body's own immune system.
Right.
to heal it, which I just,
I mean,
yeah.
yeah, exactly. And there's many PRP studies kind of showing like promising results as we speak.
Mm-hmm.
Kind of like showing this augmenting natural healing response
Yeah.
to produce stronger bone when you have a fracture,
Mm-hmm.
regenerating tendon and muscle when you tear them, and increase vascularity to the tissue, all in short time period. And this is we usually call it as a regenerative medicine.
Mm-hmm.
And this is, you could compare it to cardiology, interventional cardiologists. So interventional cardiology wasn't around till I think 1979 or 1980s. So before, if you had any heart issues, it was either the primary care would treat your heart or the surgeon. There was no middle ground to do sort of stenting or angioplasty, none of those business.
Right.
So basically it was black or white. You just either take the medicine and hopefully you won't die, or you actually, the surgeon, the cardiothoracic surgeon would open up your chest and do a triple bypass. So there was no middle ground. And now with this regenerative medicine, or it's called orthopedic medicine, this is the common ground, the middle ground between primary doctor or ER doctor treating a patient with just kind of ice and basically elevation and pain medicine, versus going to the OR under orthopedic surgeon knife and get open.
Yeah.
So now we could just use a needle by either PRP or stem cell.
Do you foresee a day where a woman or a young girl will be able to get a vaccine against breast cancer?
Well, I think that's the hope, though. We want to stop women from dying of breast cancer.
This is Christy Maya. She is the director of research at RadNet and the board president and director of the Cancer Research Collaboration Foundation. I love speaking with Christy because she is so knowledgeable and has so much intel on incredible developments in the world of cancer research. And she's also the nicest person. Hi, Christy.
Hi there.
Thank you for joining me today.
Sure, it's great to be here.
Hey, I'm so glad. So our main topic today is immunotherapy, but we're going to talk with you about some vaccines that kind of, I guess, came out of that whole immunotherapy universe, I would say, right?
Sure. Well, I think cancer vaccines are a pretty hot topic, and part of immunotherapy is also the approach of immunological vaccines to target certain things with cancer.
Yeah. Okay. So there's a few that we were going to talk about today. So first of all, explain to me about how vaccines work.
So for cancer vaccines, which we'll specifically talk about, there's two vaccines right now that target viruses. Mm-hmm. And so how it works is vaccines contain dead virus, which is used to train the immune system to recognize it and react quickly when it encounters the live virus.
Okay. So what are some of the vaccines that are available that will prevent cancer?
So there's two vaccines currently available to prevent cancer. One is for HPV, and this is, people hear it as Gardasil. There's out there, you can hear the commercials and everything. Right. So the HPV vaccine teaches the immune system to see the HPV virus as something foreign and an invader, and then it goes after. This vaccine can prevent cervical cancer, anal cancer, and certain forms of head and neck cancer. Mm-hmm. And then the other preventative vaccine that's been approved and that's in use is the hepatitis B vaccine, which teaches the immune system to recognize the Hep V virus, which may lead to chronic liver infections, but also liver cancer.
Okay. And so the HPV, that's the vaccine that they like to administer to preteens and teens, right?
Mm-hmm. Mm-hmm. Mm-hmm.
Okay. So what other vaccines are in development or in the works?
So breast cancer vaccines that are being developed for that use, they don't recognize viruses, but what they're doing is they're going to use the body's own immune system to fight the cancer. Mm-hmm. So for breast cancer vaccines, they're a little bit more personalized, more targeted, and and they're going after, pretty much the focuses are early stage breast cancer to prevent reoccurrence, or metastatic disease to treat it and stop the spread of metastatic disease.
Wow. That's so somebody who's, say, newly diagnosed, like, who would be a candidate?
Well, right now they're all in clinical trials. Depending on what they're looking for, and I looked the other day just to make sure, there's about 34 clinical trials going on clinicaltrials.gov, looking at cancer vaccines.
Wow.
Some of them are different, but if you go, you'll see some that are breast cancer, but they're for other they can apply them to other things. So some of the vaccines that are in clinical trials are, one is targeting the HER2 protein. So you've heard of HER2 new protein, and that's one of the markers that women get when they're diagnosed with their breast cancer. And then there's another trial that is looking at mammoglobin A, which is only found in breast cancer cells. So and then another vaccine that's in clinical trials is targets folate receptor alpha. So folate receptor alpha is found in 86% of triple negative breast cancer cells. Wow. So those are, 3 of the breast cancer strategies for vaccines that are out. There's other ones, and there's more coming out every day because the technology is just rapidly advancing.
That is amazing.
So most recently, in January of this year, it came out with a lot of excitement and everything. Yeah. It was announced that there would be a preventative vaccine entering clinical trials, the FDA approved, and that it would be starting in the spring. And this vaccine would potentially prevent breast cancer. Wow. So the initial focus of the vaccine will be targeting triple negative breast cancer. So triple negative breast cancers account for about 10 to 15% of all breast cancer cases. And another reason is triple negative breast cancer patients have fewer treatment options and worse prognosis than other types of cancers. Yeah. So the idea of prevention in this setting is pretty exciting just because of the poor prognosis for these patients. Yeah. So this vaccine works by immunizing against the protein called alpha-lactalbumin, which is expressed in women's mammary glands later in pregnancy and during lactation.
Do you foresee a day where, a woman or a young girl will be able to get a vaccine against breast cancer?
Well, I think that's the hope. When vaccines first came out and were being used in treatment, it wasn't effective. I mean, a breast cancer vaccine, the idea of developing one has been around for a long time, 20 plus years, and but they haven't been effective. But I think with the new targets, the proteins, this approach, that we're seeing better and greater advances and more response to them. Right. So.
And has this been as a result of developments in the whole immunotherapy world,
definitely.
Like learning how to harness the immune system and that
definitely
kind of thing?
Yeah,
it's really amazing. It really is. And so where can people find out more about vaccines and clinical trials, or if they want to participate?
Yeah, so 2 of the best sources is to go to clinicaltrials.gov, and then there's another website called breastcancertrials.org, and you can search for breast cancer vaccines or for vaccine and come up with the clinical trials. On clinicaltrials.gov, it'll tell you which ones are enrolling, if they're open, and what centers they're in.
Right. That's fantastic. Wow. Very cool. Exciting stuff.
It's very exciting. Yeah. I mean, and the hope is, the idea is, people who have hereditary cancers, who have BRCA1, BRCA2, these types of things that hopefully in the future, should you be able to receive a vaccine and prevent that, think of it in terms of, if you're predisposed and then you have a daughter and they have a daughter, and you see that in families, and it's just devastating. So this is an opportunity to, affect generations of women against breast cancer.
And, I know of people who've, tested positive and have prophylactically had a mastectomy and a hysterectomy. So this is sort of an, obviously a much better option for people down the road, hopefully.
Well, and even if the surgical option is there, still post-surgery, if you can get a vaccine to prevent, because some of those patients will have an occurrence of their cancer even after that. And so hopefully this is an option. And that's why preventative vaccine, the strategy's been that, to stop it from happening and then to stop it from progressing. That's what everybody wants to see. Because if you have it, you want to stop it from progressing into metastatic disease and taking over things that then can't be repaired. And if you don't have it, but have a huge family history, or you're gene positive, or you happen to be, have an early stage breast cancer, you want to make sure that it doesn't turn into something that can't be taken care of.
Yeah, absolutely. That's really amazing. Really amazing. Very cool stuff.
Yeah, it's an exciting time, I think, more so than, and I think that the years, it would be years and years till you would hear about really, super great advances. And now, like I said, in January, they came out with this press release about this preventative vaccine at the Cleveland Clinic. And then, and there's these other approaches, and it's just moving faster, and the advances are coming closer and closer together, which means we're going to get there sooner.
It's a time of optimism in cancer medicine.
I wanted to revisit this quote from Dr. Hoffman here again, because it's not often that you hear the words optimism and cancer used in the same sentence. But I do think if we can get anything out of the conversations we had in this episode, it's that we really are living in an exciting time in terms of medical advancements for treatment of cancer and other diseases, as well as for injuries and chronic pain. We're also living in a time of patient empowerment. So understanding your options and what's out there and what you can ask for is so important. You do have a voice in your own healthcare and treatment. And just to reiterate, if you are interested in more information about participating in clinical trials, you can visit clinicaltrials.gov or breastcancertrials.org for a list of all the open trials. On the next episode of Your Body, we're diving into genetics, genetic testing for diseases, high-risk assessment, how this is all evolving, how to get tested, and what it means if you do have a gene mutation. I'm actually going to take a genetic test and have a genetic counselor read my results on the podcast. Knowledge is power, people. Thanks for listening. If you want to learn more about this HealthCast or some of our guests, please visit www.yourbodyshow.com. And if you'd like more information about RadNet, check out www.radnet.com. Your Body is produced by Steve Kramer, Doug Smith, and me, Stephanie Landon. Technical and research assistance provided by Joseph Wilson. Executive produced by Paul Colacchio and Karen Morad, all on behalf of RadNet. Original theme music by Mark Lakeyear. We hope you've enjoyed our HealthCast. Find us wherever you download podcasts.